Petr Ostadal and Mike Gibson coming to you live from AHA 2022, and we are talking about ECMO in cardiogenic shock patients. Lots of mechanical support being used out there, lots of ECMO being used out there. You, Petr, did a study looking at early aggressive ECMO versus a conservative approach. What did you find?
No, exactly. We performed a study to compare early ECMO and early conservative therapy. And in the early conservative therapy, there was allowed to use ECMO in case of further hemodynamic worsening, which was clearly defined by the rise of lactate by at least 3 millimoles per liter. And the results of our trial are neutral. We didn't find any significant difference between the incidence of the primary composite endpoint, which was the death from any cause, resuscitated cardiac arrest, or implementation of another mechanical circulatory support. And there was no difference between the immediate ECMO and the early conservative therapy.
And no difference on the other side in terms of safety, bleeding, or complications, correct?
Absolutely. The overall incidence of the serious adverse events was almost the same, 60 and 61%, and also the individual incidences of bleeding, stroke, like ischemia, pneumonia, sepsis were statistically not different, were very comparable.
And a lot of crossover. So a fair number of those people in the conservative strategy ended up getting ECMO. What was that number again? 39%?
39%,
Yeah.
exactly. Yeah.
So it's a comparison really of an early versus delayed or conservative approach. It's not really an ECMO versus no ECMO comparison, right?
Absolutely. It was a comparison of immediate ECMO versus early conservative therapy. But in the early conservative therapy, the use of ECMO was allowed in case of hemodynamic worsening defined by the rise of lactate. This was the 39% in the early conservative therapy, which received ECMO later during their hospitalization.
Now, looking at the event curves, what I thought was interesting is there was some separation early on where ECMO was a little better, but then those curves came back together by 30 days. What happened there?
That's a good question, and it's not easy to answer that. But you are right. During the, let's say, first 6 to 8 days, there was a separation with a lower the Kaplan-Meier curve for the early ECMO. It can be speculated that this difference was because of ECMO was a bridge to not a bridge to recovery, but more the prolong the time to that in comparison with the early conservative therapy where the ECMO was not used and the primary outcomes was observed earlier.
So, to put it simply, you were just delaying the inevitable, perhaps, is one way to look at it. Well, where's your practice stand now? Are you going to be still using an early aggressive approach, or are you going to use a conservative approach?
I certainly don't think that ECMO should be forgotten. However, based on these results, I think that the insertion of ECMO is not necessarily the first step in patients just admitted because of cardiogenic shock to emergency department or just transferred from another hospital. We can start with vasopressors and ionodrops. We can provide proper examination, start close hemodynamic monitoring, and based on the data we obtain and based on the results of other investigation, we can decide whether to use mechanical circulatory support or not use.
Well said. Thanks for joining us, and thanks to all of you for joining us here live from AHA 2022.